Just a minute. Yes, we are live now. We can start with the session.
Okay, good evening. I'm Dr. Anirban Rai. The topic I'm going to talk about today is single inhalational triple therapy, a new era in nebulization. Burden of the disease is the first topic which I'm going to talk about. LABA or LAMA and LABA-LAMA ICS are the preferred combination used for the treatment of COPD Gold, Stage B and E2. However, more than 60% of the treated COPD patients remain symptomatic. Despite dual or triple therapies, COPD patients continue to suffer 2 to 3 exacerbations annually. Nearly half of them with severe disease experiencing more than equals to 2 exacerbations per year. Current challenges in high risk symptomatic COPD patients. Suboptimal PIFR seen in 86% of the Indian population of COPD patients. Cognitive, that is 3 patients, and physical limitations. High error rate with inhalers. The outcome is uncontrolled symptom exacerbation. The solution is need for a consistent effort and error independent maintenance option ensuring sustained bronchodilation. The COPD exacerbation journey at emergency and ICU, in ward, at discharge and first follow-up. Acute exacerbation of COPD management recommendation from Gold 2025 shows increased dose and frequency of short-acting bronchodilators and switch to long-acting bronchodilators as soon as the patient is stable enough. Then I shift to current challenges in exacerbation management in emergency and ICU. High frequency of dosing, that is 12 to 20 doses per day. Beta 2 receptor desensitization with repeated SABA exposure. No added benefits with higher doses and diminishing responses. The outcome is limited bronchodilation despite frequent use. The solution is need for a combination, reducing frequent dosing needs and enabling early seamless transition to a maintenance therapy. Acute exacerbation of COPD management correct challenges in the ward. Continued Sabasama use beyond 48 hours despite stabilization. Delayed switch to long-acting bronchodilators. Early switch to inhalers MDI DPI despite suboptimal PIFR. 52% have inadequate drug deposition with inhalers at ward. Reliance on multiple respule nebulization, currently available nebulization LABA plus LABA or ICS combination. The outcome is delayed recovery and prolonged hospitalization. The solution in this case also is a device and drug combination which can offer effort and error independent sustained bronchodilation, ensuring continuity of care from ICU to discharge. ACOPD management current challenges at discharge. Limited triple therapy use at discharge. 53% of null triple therapy, mainly discharge on dual therapy. Suboptimal discharge protocol, that is increased risk of subsequent exacerbation. And third is device mismatch, which is 61.6% of the patient during discharge had low PIFR. Females, old age, IHD patient, hypertension and diabetes mellitus being the common of them. Outcome is increased risk of subsequent exacerbation and increased high readmission rates. The solution in this case also is an optimal device and drug combination, ensuring optimal discharge care. Now I would address the challenges across the continuum of the care. Journey of COPD patients, which are divided into home maintenance, long-term, emergency and ICU, ward, discharge and home maintenance till immediate before the first follow-up. The current challenges in home maintenance, this is a screenshot of all the issues I have spoken. The current challenges, first one is low and suboptimal PIFR in home maintenance, cognitive physical limitation. Third one is high error rates. In emergency and ICU, it is limited bronchodilation despite frequent SABA-SAMA use. Ward, it is continued SABA or SAMA, delayed switch to LABA, multiple response nebulizer. And in discharge and home maintenance, this is suboptimal escalation to triple therapy, persistently low PIFR and device mismatch. The solution in first 3 cases, that is home maintenance, ER and ward, is an effort independence device ensuring optimal lung deposition with convenience. At discharge and home maintenance, immediate before first follow-up is powered by a trusted triple combination LABA-LAMA ICS, ensuring effective symptom control and long-term COPD stability. The innovation is single nebulization triple therapy, the drug being Nebsmart GFB with a combination of formoterol, glycopyranum, and budesonide smartules. Now, the composition of each of the smartules is each 2 ml consists of glycopyranum 25 microgram, formoterol 20 mcg microgram, and budesonide 500. It is approved indication only for COPD. One respules twice daily, that is the treatment dosing. Now, there is an Indian evidence of phase 3 clinical trial, Nevsmart GFB versus PMDI GFB. The PMDI consisting of formoterol fumarate dihydrate 5 microgram, glycopyranum 7.2, and budesonide 160. The baseline parameters in the study was total study population of 314 patients, the mean age of them being 58.5, the patient gender being males 53 and female 46.1. The baseline lung function of the patients were either gold grade 2 or grade 3. Gold grade 2 meaning moderately severe obstructive airway disease with a FEV1 of 50 to 80%. 38% of the patients were them. Second one is gold grade 3, that is severe with a FEV1 between 30 to 50% predicted. 61% of the patients were between this range. And dyspnea severity, modified medical research council score of 2 up to 27% of the patients and more than to 70% of the patient. Next, I would talk about the study design. Study design consists of number one, diagnosis of COPD, post bronchodilator FEV1 by FVC less than 0.7%, post bronchodilator FEV1 more than 30% predicted and less than 80% predicted at screening visit. History of more than equals to 2 moderate exacerbation of COPD or more than 1 exacerbation of COPD leading to hospitalization. Subject on LABA plus minus ICS, LAMA, LABA and LAMA for at least 1 month before screening. Absolute baseline eosinophil count of more than equals to 300 cells per microliter. Exclusion criteria was patient with concurrent asthma or with the treatment of concurrent triple therapy. Follow-up was 12 weeks. Arm 1 consisted of nebulization glycopyranum, formoterol and budesonide smartule using jet nebulizer. Arm B was an inhaler MDI consisting of glycopyranum, formoterol and budesonide 160 microgram. End of study was 1 week follow-up. So basically, this study is a multi-center, randomized, double-blind, double dummy, parallel group, non-inferiority study. Now I will come to the study endpoints. The primary endpoint was change from the baseline in trough FEV1 in 1 second at week 12. Next, change from the baseline in trough FEV1 at week 4 and 8. Next is change from the baseline 2 hours post-dose FEV1 at week 12. Rescue medication used averaged over week 11 and 12. Change from the baseline in trough FVC at week 12. Change from the baseline in modified medical research council score at week 12. Treatment emergent adverse effects, frequency of exacerbation, vital signs, ECG parameters, and lab parameters were checked at the efficacy endpoint. Now I will talk about the changes which we got at the end of the study. At the end of the study, we found that primary endpoint was met. Improvement with Nevsmart GFB was non-inferior with the inhaler MDI GFB in group in week 12. Mean change from baseline in 2 hours post FEV1. Statistically superior improvement in 2 hours post-dose FEV1 on day 1 in Nevsmart group versus MDI group. Numerically larger improvement in 2 hours post FEV1 at week 12 nebulization group versus MDI group. So the inference is statistically significant. Superior improvement was seen in 2 hours post-dose FEV1 from group from baseline on day 1 in Nevsmart GFB group, which continued through week 12 as compared to PMDI GFB group. And next, I would check about the mean change from the baseline in MMRC score. Superior improvement in MMRC score was seen in Nevsmart GFB as compared to PMDI GFB group. Greater reduction in MMRC with Nevsmart GFB indicates superior dyspnea relief, improving daily function and quality of life. Another parameter which was checked was rescue medication which was used. Significant reduction in the rescue medication used in Nevsmart GFB as compared with the improvement in two other groups. Mean change in trough FVC from baseline, significant improvement from baseline to week 12 was seen in trough FVC in Nevsmart GFB group with comparable improvement in both the arms. Next, I come to the summary of the treatment emergent adverse effects. Subject with at least one treatment emergent adverse effects related to the study drug detected by severity, mild, moderate, and few other headings are there. It shows Desmart GFB was safe and well tolerated with no serious or severe treatment emergent adverse effects or death during the study period. Most common treatment emergent adverse effects are pyrexia, number one. Number two is nervous system disorder, which is headache. Respiratory, thoracic, and mediastinal disorders includes cough and COPD. Most common treatment emergent adverse effects reported was pyrexia, headache, cough, exacerbation of COPD in both Nevsmart GFB arm and in PMDI arm. Other safety endpoints which were checked was overall 4 COPD exacerbation episodes were reported, 2 being mild with Nevsmart GFB versus 2 being one with mild and one moderate with PMDI GFB. Majority of the exacerbations were mild in intensity, with one in PMDI GFB group being moderate, leading to drug discontinuation. Biochemical and hematological values were normal in both the arms, with baseline and post-baseline visits suggesting a no clinically meaningful impact. Vital signs. Majority of the subjects in both groups had normal vital signs values at both baseline and post-baseline visits. হ্যালো, শুনতে পাচ্ছেন?
হ্যাঁ স্যার, শোনা যাচ্ছে স্যার।
এখানে উপরে একটা লেখা আসলো টেকনিক্যাল টিম ক্যানট হিয়ার ইউ।
আচ্ছা
আচ্ছা, majority of the subjects in both the group had normal vital signs values at both baseline and post baseline visits, no clinically meaningful changes. ECG changes. Majority of the subjects has clinically non-significant 12 lead ECG values in both the arms, no clinically meaningful changes from baseline at week 12 in the ECG parameters. Nevsmart GFB demonstrated a favorable and comparable safety profile to PMDI GFB with no new safety concerns or clinically meaningful changes observed. Now, coming to the summary of phase 3 clinical trial, Nevsmart GFB in COPD patients. Number one, primary endpoint met was Nevsmart GFB consisting of glycopyridinium, formoterol, and budesonide was non-inferior to MDI at week 12, number one. Number two, what we got was improved lung function versus baseline. Statistically sustained significant improvement in the trough FEV1 at week 4, 8, and 12. Relatively faster bronchodilation, superior 2 hours post-dose FEV1 on day 1 versus MDI. Symptomatic benefit, significant MMRC improvement nebulized showed superior MMRC at week 12 versus MDI. Less rescue medication used, reduction in rescue medication used from the baseline. And lastly, the safety profile of Nevsmart GFB were comparable with reference to the nature, frequency, and severity of treatment emergent adverse effects. Now again coming to the composition again, this one Nevsmart GFB consisting of glycopyridinium 25 microgram, formoterol 20, budesonide 500 micrograms, which is usually dosed twice daily, one in morning, one in afternoon, via jet nebulizer. Next, coming to why do we put the patient on nebulization? There is a study which is done by Indian stalwarts, namely from Kolkata, Raja sir, Angshuman sir, then DJ Christopher sir, Deepak Talwar, Gopi C. Chanani, Indranil sir, and one of the localite of Bahrampur, Joydeep Ganguly, and Parvez A. Kaul, Prashant Chajar, Vikram Jaggi and Vinit Hirane. It showed the positive impacts which showed why we should give nebulization in COPD maintenance management was the patients with cognitive impairment due to age or comorbidity, number one. Number two, in those patients who are unable to use any handheld inhaler despite repeated instruction and training, reduced manual dexterity due to age or comorbidity, that is, the patients with Parkinsonism, Alzheimer's disease in them, patients who cannot generate PIFR, particularly after debilitating hospitalization, and patients with muscle weakness or pain due to neuromuscular comorbidity. And lastly, patients who are inadequately controlled by a PMDI or DPI or who needs higher dose of medication. Now, nebulization, the preferred choice of COPD patient, better symptomatic relief. 75% of the patients reported greater symptomatic relief with nebulizer than with inhaler. Greater adoption among severe symptomatic patients with a MMRC grade more than 2 were most likely to use and benefit from nebulizer. Comfort and confidence at home, nebulization made patients feel more comfortable and confident in control of their treatment, enhancing comfort control and symptom relief in real world COPD management. Strong patient and caregiver preferences, 80% of the patients and caregivers preferred nebulizer therapy for symptom control and quality of life. Next, coming to the evidence landscape. Triple therapy, a well-researched, clinically proven and trusted choice in COPD management. Figure shows change from the baseline in trough FEV1 at week 52 and rate ratio of moderate to severe exacerbation. Pivotal trials and pooled analysis have shown clinically and statistically significant improvements in the lung function and exacerbation reduction with BGF triple therapy versus dual therapy. NEPSMART GFB combination, the evidence in exacerbation management, evolving evidence, nebulized long-acting bronchodilators in hospitalized COPD patient. Long-acting bronchodilators nebulization therapy can be a potential alternative clinical strategy for management of hospitalized acute exacerbation of OED patient. Next is global evidence from CHEST 2021 and 2023 demonstrates that long-acting bronchodilator nebulization is an emerging evidence-based option for hospitalized COPD patient, ensuring effective effort-independent bronchodilation and smoother transition to maintenance therapy. Feasibility, safety, and efficacy of nebulized long-acting bronchodilators versus nebulized short-acting bronchodilators in hospitalized patients with exacerbation of COPD. This was the study, and the findings which came out, it's given in the footnote. Finally, the recommendation from Indian experts, nebulization and acute exacerbation of COPD management, abstract number 8, evaluating the role of nebulized glycopyrronium in hospitalized patient with exacerbations of obstructive airway disease transitioning from hospital care to discharge. Again, the study method include 120 physicians across India were invited to participate in structured survey with 10 questions on preference of therapy in OAD. Study population one was 101 physicians actively participated. Almost half, that is 48% of the participating physicians preferred NebSmart glycopyrronium, nebulized glycopyrronium based combination therapy in emergency and ICU. Majority 60% preferred nebulization glycopyrronium based triple therapy in ward once patients are stable. 43% preferred nebulized glycopyrronium based triple therapy at discharge from home nebulization. Rapid and sustained effect of nebulized glycopyrronium makes it an emerging choice among physicians for OAD exacerbation, especially in severe cases. Early initiation of nebulization glycopyrronium combination and its continuation till discharge indicates its full utility and transitioning care. Now, I would like to share my personal experience in this one. Once this was launched and was informed to us about its availability, I have tried in few of my patients in Kolkata as well as in Boharampur in other peripheral smaller districts as well as in Malda. I have seen the exacerbation rates to reduce to a very, very large amount when I put the patient on NaveSmart GFB. But one more thing I would like to add, the patients were in acute exacerbation. I had also used steroids. So I don't know which one was the main factor which worked for the patient. But my personal experience was all the patients in which I tried NevSmart GFB, the patients got relief quite early. In them also, in home also, I have used NevSmart GFB after discharge. Symptomatic high risk patients, sustained control for long term stability, patients with cognitive impairment, neuromuscular comorbidity, suboptimal PIFR, reduced manual dexterity, unable to use DPI, MDI, inadequately control an inhaler. At ER or ICU for early initiation and faster stabilization, reduced frequent reliance on SABA or SAMA, sustained bronchodilation and faster stabilization in ward and a discharge for seamless transition from hospital to home. Effort and error independent delivery, seamless transition supports optimal recovery. At the end, the key takeaways are multiple challenges still exist in overall COPD continuum of care. Inadequate therapy and incorrect choice of device significantly impact the treatment outcomes. Nebulization which do not require coordination of actuation and inhalation or an inspiratory flow threshold represent a promising suitable alternative in high risk patient. Single nebulization triple therapy has shown to be non-inferior to GFB in PMDI, improving lung function with better symptom control than existing PMDI. Growing evidence of early adoption of triple therapy early in exacerbation management significantly improves overall treatment outcomes. Thank you.
Thank you, sir. And sir, if you allow, there is a one another some 10 slides that shared by our head office for the benefits of nebulizer. So if you allow, I can share this 10 slides. If you guide the audience, what is the benefits of nebulizer?
ঠিক আছে পাঠান আমাকে হোয়াটসঅ্যাপ করুন আমি খুলছি আবার শেয়ার করছি
আচ্ছা আচ্ছা ওকে স্যার
এটা তাহলে স্টপ শেয়ার করি
হ্যাঁ হ্যাঁ হ্যাঁ
এটা ক্লোজ করলাম আবার হোয়াটসঅ্যাপে যাচ্ছি
হ্যাঁ স্যার আমি সেন্ড করছি
Hello.
Yes, ma'am.
You can conclude the meeting.
No. There's one PPT that's completed. So the next there is another 10 slides are there. So doctor is just sharing.
Okay.
আমি ওপেন করে আবার কানেক্ট করছি ওই এটা।
হ্যাঁ হ্যাঁ ঠিক আছে স্যার।
দেখতে পাচ্ছেন?
হ্যাঁ দেখা যাচ্ছে স্যার লাস্টে।
করে দিচ্ছি। At the end, I would like to talk about the benefits of nebulization. First of all, nebulization are from multiple types. As per my knowledge, number one is jet nebulizer, mesh nebulizer, few many more other types are there. Now, the benefits of nebulization are high dose of medication can be given to the patients who are not able to coordinate with other devices meaning handheld devices, for example, DPI and MDI. Third one is best resort to give optimal dose and targeted drug delivery. Now, what is a nebulizer? It delivers a therapeutic dose of drug as an aerosol in the form of respirable particles within a short period of 5 to 10 minutes. Now, they have also mentioned the types of nebulizer. Number one is jet nebulizer, which are simple, inexpensive, and most commonly used. Second one is ultrasonic nebulizer, are not suitable for the use for suspension or viscous solution. Third one is mesh nebulizer. Vibrating mesh nebulizers are more efficient but expensive. Parts of the nebulizer system consist of the following parts. First one, compressor. Second one is tubing. Third one is nebulization chamber. Fourth one is mask and mouthpiece. Now, ABC of nebulizer consists of assemble, breathe, and clean. Assemble steps you in the nebulizer. লাস্ট চারটে স্লাইড কিন্তু একদম দেখা যাচ্ছে না, তার উপর ছবি চলে এসছে। আইফোনের জন্য হচ্ছে কিনা জানি না, স্ক্রিনশট মে পাঠাচ্ছি একটু পরে আপনাকে। যেটুকু পড়া যাচ্ছে সেটাই আমি মানে রিড আউট করছি।
আচ্ছা
অ্যাসেম্বল স্টেপস ইউজড ইন দ্য নেবুলাইজার। দাঁড়ান আপনাকে স্ক্রিনশটটা পাঠাই, এটা কিছুই পড়া যাচ্ছে না লাস্টের কয়েকটা স্লাইড।
স্যার ওটা কি আমি শেয়ার করবো স্যার?
করুন করুন।
তাহলে আপনারটা ওই স্টপ শেয়ারিং করে দিন, আমি শেয়ার করছি লাস্ট
ঠিক
চারটে
আছে ঠিক আছে। এটা হয়ে গেছে।
হ্যাঁ স্যার।
Steps used in the nebulizer. Number one is before assembling the nebulizer, wash your hands properly. Second one is correctly assemble the nebulizer as per the manufacturer's instruction. Third one, unscrew the top of the nebulizer chamber and carefully pour the prescribed medicine into it. Fourth one, close the top of the nebulizer firmly and ensure it is not loose. Thereafter, connect one end of the tubing to the nebulizer chamber and another end to the compressor. Assemble the mask or mouthpiece properly in the position above the nebulizer chamber. Ensure that all the connections are secured tightly. Connect the assembly to the power source and switch it on. A mist should start coming out from the mask or the mouthpiece. Next. পরেরটা।
হ্যাঁ স্যার জাস্ট প্রবলেম হচ্ছে।
এটা বললাম।
হ্যাঁ স্যার এক সেকেন্ড।
Now coming to B, which is breathe, correct positioning and guidance. The nebulizer is ready to be used once it is switched on and the mist appears from the mouthpiece or the mask. Place the mouthpiece in the patient's mouth. and have them close their lips around it or place the mask on the patient's face. Make sure that the patient is in an upright position and comfortable position. Explain to the patient to breathe normally through their mouth with occasionally deep breaths. Advise the patient not to talk during the entire nebulization process. Ensure that the nebulizer chamber is held in an upright position and not tilted to prevent the dose from spilling out. Instruct the patient to tap the chamber intermittently to prevent aerosol condensation. Switch off the compressor once the mist formation has stopped. Discard the leftover solution in the chamber. Cleaning and disinfecting the nebulizer. Frequency of cleaning. Once the nebulization process is complete, disassemble its part, remove the tubing and set it aside. Do not wash or rinse the tube from the inside, but you can wipe it from the outside with alcohol. After each use, clean the nebulizer cup and mouthpiece with sterile or distilled or warm water. The final rinse should be done using sterile water, not distilled or bottle. To make sterile water, boil tap water for 5 minutes. Shake off excessive water and attach the gas flow to the nebulizer for a short term to aid in drying better. Place the parts on an absorbent towel and allow them to dry. Once dried, store the parts in a dry bag and keep them in clean place. For cleaning and disinfection done for once or twice a week, wash the nebulizer parts with warm water and liquid soap. The final rinse should be done with sterile water. Disinfection. Infection control for patients can be achieved by taking appropriate measure before and after every use. Disinfection of nebulizer after each cleaning is crucial to reduce the chance of bacterial contamination. For disinfection, nebulizer parts can be soaked in the following solution, not recommended for cystic fibrosis patients. A solution of 1 part household bleach and 50 parts water for 3 minutes, 70% isopropyl alcohol for 5 minutes, 3% hydrogen peroxide for 30 minutes, 1 part distilled white vinegar in 3 parts hot water for 1 hour. Boil or microwave the nebulizer parts for 5 minutes. Finally, rinse step not required. Alternatively, wash the parts in dishwater at a temperature of more than 158 degree Fahrenheit, 17 degrees centigrade for 30 minutes. Final rinse step not required. Always follow the manufacturer's instruction for cleaning and disinfection. Disinfection frequency. Nebulizer for bronchodilator therapy. Clean at least once a day, 1 day at a time. Nebulizer for antibiotic. Clean after each use. Please clean after each use. And nebulizer after every 30 uses, nebulizer accessory should be boiled for 5 to 10 minutes with little detergent. Nebulizer accessories that are not used for long time should be cleaned before further use.
So, thank you, sir. This is the last slides for our nebulizer benefits.
Thank
So
you.
we are waiting for some question answer session. So when we get jot down all the questions, and after 2 to 3 minutes, I will ask.
Okay.
স্যার
বলুন বলুন।
হ্যাঁ বলছিলাম কয়েকটা কোশ্চেন পেয়েছি যে অডিয়েন্স থেকে। তো
বলুন।
ফার্স্ট কোশ্চেন যেটা করেছে যে হাউ মেনি ডেজ উই ক্যান গিভ এসএনটিটি।
হাউ মেনি ডেজ?
হ্যাঁ ইয়েস স্যার।
Depending on the situation, for example, as I said, my personal experience, the patients which are arrived in emergency, suppose I would try them in acute exacerbation on SNDT, and that is day-to-day basis. As soon as the exacerbation reduces, we can switch to later on to maintenance. I'm not telling, meaning on a short-term basis, at least for 7 days to 2 weeks, we can use if we are using for acute phase as well as for maintenance phase. If we are using only for acute phase, then we will use it for 3 to 4 days. Once the patient exacerbation has reduced, we will be switching to SAMA and LABA ICS combination. Depends on the physician. I have personally used it for both emergency purpose as well as I have used it for maintenance purpose. For my case, I have used it for almost 14 days continuously.
Thank you, sir.
Hmm.
And another question has come ki how much effective SNTT over SITT?
SITT. Okay. The entire discussion was about this topic only. All the researches which were done and the studies that has been done till now, even though they are less, more studies need to be done. But whatever studies has come across till now, SNTT is quite effective, equivalent, or even more effective than SITT. There is no issue, and it is much more better in the patients in whom coordination is a issue, who requires nebulization. For example, Parkinsonism patient, elderly, debilitating disease, Alzheimer's disease. In those patients, I would prefer SNTT. So the question, if it is which is better, or whether it is equivalent in efficacy, it is almost equivalent in efficacy as compared to SITT.
Thank you, sir. Sir, another question is come ki if patient is uncontrolled, can we give 3 to 4 times of SNTT?
That study I am not aware of. Till now, the guidelines which we have been given is only twice daily SNTT. For example, Nevsmart GFB, we usually give twice daily. Not like the previously any patient who comes on exacerbation, we are giving every 5 minutes or 10 minutes nebulization with duolin or Sabasama combination. We don't do that with SNTT. We usually give it twice daily, not 4 or 5 times per day. Not as per my knowledge. Usually twice daily.
Thank you, sir. And another question has come ki in the time of discharge, what do you prefer, MDI with spacer or nebulization?
Uh, as per the teaching which I received from my teachers at Fortis Hospital, Kolkata, usually exacerbation patients with obstructive airway disease, usually we discharge with on nebulization. After 2 weeks, suppose they follow up in OPD, we change into inhalers. That is majority, around 70 to 80%. Remaining 20% whose exacerbation has reduced in the hospital itself and they are very stable in them, we discharge the patient on inhaler. For example, PMDI.
And another question is come ki will you use ICS Labalama as rescue medication because of now Labalama also have quick onset of action.
I didn't understand the question.
His question is coming that ki will we use ICS Labalama as a rescue medication?
Yes, yes,
Because
I'm telling that if a patient arrives on emergency, I have used for my patients. So they have got benefit. But only doubt which I had is the patients also received oral and IV steroids. So I don't know which one gave so fast relief to the patient. If you ask me by my personal experience, till the time from the time it has been launched, the use response from the patient was very good. Meaning all my patients recovered. I have discharged them on maintenance also with Nevsmart GFB. I have not got back the patients again coming to emergency very fast. The response was good in emergency or ER setup, what you are asking.
thank you, sir. So
Yes.
there is some repetition question has come. So if there is any new question has come, I will ask, sir.
Okay, it's almost 1 hour. Can we end?
Sir, one new question has received. Patient with comorbidities like heart failure or cardiac patient, can we take SNTT and how long?
Again, SNTT doesn't have a specific contraindication like in these patients you cannot give them. So any patient with comorbidity like kidney, liver, heart, there is no issue at all to give SNTT. As per my knowledge, definitely all the drugs have specific meaning complications, which happens in if we give divided dose, then also these complications will happen. For example, LAMA will cause acute retention of urine, may cause. It may cause dryness of mouth, it may cause exacerbation of glaucoma. So specifically SNTT causing this complication, it is not there. So the question being, any patient with comorbidity, can we give SNTT? Yes, we can give SNTT. There is no issue.
Okay, sir. And another question is, you are using SNTT and how you follow the stepwise approach.
Stepwise approach. Okay. Initially, the patient coming in emergency in an acute exacerbation status with shortness of breath, with wheeze, with desaturation. I started the patient on this one. My preferred thing, which I usually did, I will tell you. One is I gave only Livolin plus Nevsmart GFB to the patient at emergency. I would follow up him with ABG, serial chest X-ray, and then saturation probe. I will check how much is his saturation. Suppose after 24-hour patient is improving, not improving, I'll give oral or IV steroids. If he is improving, I'll slowly reduce the dose of rescue medication. For example, Livolin. But Nevsmart GFB, I will be continuing thereafter after the patient steps down from emergency or ICU to HDU, then to ward till maintenance at discharge. So my total duration of treatment from ER or ICU till discharge will be almost around more than 2 weeks.
Thank you, sir. And one question has come, can you share some lights on gold update and in where we can put SNTT?
Gold update, SNTT. The latest gold guidelines I have not gone through, which has come in the last year. So this question I would like to skip because I need to go through my. I'll just go through the latest guideline. This question I'll just skip.
Okay, sir.
Mhm.
So, what will be? There is a two question is come. In
Mhm.
ACOS, can we start treatment with SNTT? And what will be the ideal treatment of ACOS?
Asthma COPD overlap, as per the slides which I just read out, and also the different clinical trials which has been done, they are showing the exclusion criteria of using SNTT is asthma patient because they are already in LAVA ICS. So I would suggest not to use in the patients with asthma COPD overlap, but only to use in the patient of COPD because the drug itself tells that it only it is recommended or it is allowed as per government guidelines to be used in COPD patient. So not in ACOR. And next question comes is how to treat with ACOS, how to go ahead with treatment in asthma COPD overlap. In those patients, mainly I would prefer LABA ICS number one. Then if it is not reducing, then I would go to suppose macrolide. If the patient is not reducing, then eosinophil count is higher. I will give oral steroids or IV steroids. But if you ask me my personal opinion, asthma COPD overlap SNTT is no, a big no.
Thank you, sir.
Mhm.
And, there is a no new questions. Already you are gave answer most of the questions.
Mhm.
Sir, one question has come ki if patient are comfortable with Savasama, then when to shift in SNTT?
If the patient is comfortable in Savasama, then I would not advise suddenly to shift the medication from one drug to another drug. Again, this SNTT is doctor to doctor dependent. I can prefer any patient from ER to ward to ICU, anywhere to start on SNTT. But if he is already stabilized on one medication, for example, LAVA ICS or LAVA LAMA, better not to suddenly shift the patient to LAVA LAMA or LAVA ICS to LAVA LAMA ICS, triple therapy. If he is already stable, better not to shift him to any other medicine.
Thank you, sir.
Hmm.
Sir, one question has asking ki difference between home nebulization and rescue medication.
Home nebulization is a maintenance nebulization. For example, we give it usually for prevention of a patient coming again in emergency, in an emergency status. Meaning exacerbation prevention is called maintenance. Or and reliever means a patient when he comes, almost the same thing. Rescue medication is when the patient has already arrived in emergency. The medicine what we are giving is a rescue medication. There is a difference. Maintenance meaning the prevention of exacerbation. The drug is called maintainer, and rescue medication when the patient is already in emergency in an exacerbation state. The medicine which we are giving is a rescue medication.
Sir, this is one question has received from our medical team. Sir, they are asking ki if vilantrol fluticasone can come in nebulization form, and
Mm.
what will be the its effectiveness and can be as compared with SNTT?
Vilantrol fluticasone. See, personally, I have not used Vilantrol fluticasone much in patients. So I would not be commenting on that. I would only comment on the medicine which I have already used. Nebsmart GHP I have used. If anybody asks me what is your opinion or suggestion, I can tell them they can use it in any patient. In maintenance or in emergency or in what they can use it. But the comparison which you are telling, since I have not used Vilor F or Vilantrol fluticasone, I will not be commenting on that.
Okay, sir.
Hmm.
Hello.
Yes, ma'am. So,
Yeah, we are done with the meeting.
we are waiting for 4 to 5 minutes, then we will close.
Okay, okay.
Shall we end now?
Okay, tech team.
Hello.
Yes, ma'am. Now it is over the 1 hour time period.
Yes, sir.
Okay, then we will close.
Okay, thank you.
Thank you, sir.
Yeah, with your permission, we'll end. Thank you.
Yes, ma'am.
So I'm exiting.
Yes, sir. Thank you very much for your time and for your valuable information about our SNTTs, and hopefully it is helpful for our attendees, doctor. Thank you very much, doctor.
Thank you. Okay.
Thank you.